Now, Guam Regional Medical City did come up in the conversation, and it had to do with whether or not they are still doing elective surgeries and things like that. And I'm frankly delighted to hear that the answer is yes. One of the concerns that everybody should have is while we're focusing so much on care and mitigation and all of that for COVID-19, there's still a whole lot of people in this town that will come up with heart issues, with respiratory issues, diabetic issues, maybe even getting themselves in an accident and breaking something, and somebody's got to go in there and put it all back together. And that's where we go with this conversation here this morning. I've got in the studio and welcoming him to Guam for the very first time, Dr. Nicholas Bandy.
Hey, good morning.
Good morning. So he's got a mask on. I've tried to get him to take it off, but apparently there's protocol, and it's not that if he's seen. If he's what was that?
Let me see those pearly whites.
I don't know. I think he's got pearly whites in it. I'm not. We've got the same forehead though. It's nice to see that we both. Yeah, it's nice to see that we both got that going on for us. But I can't get him to take it off. And the concern, and I get it. I understand. It would be terrible for the new general surgeon at Guam Regional Medical City to show up after having spent an hour with me in the studio with COVID-19 at the office. I'm sure that it would be a nick on your personal record, right?
I think that would get written down somewhere.
Yeah. Somebody would hate the idea. Anyway, Nicholas Bandy, general surgeon, new to Guam. How did besides the airplane, what was it that got you thinking about moving away from the crazy United Snakes of America and coming out here to the territories?
Well, my wife's active duty in the Navy, and so we got brought out here. We found out pre-COVID we were coming out here, and we're very excited. We're going to plan a lot of travel, but plans have adjusted a little bit.
Yeah, so you'll be doing hiking and diving and on the weekends as opposed to getting on the plane and flying into Philippines and Vietnam and South Korea and Bali and places like that. And there's nothing wrong with it. We got absolutely some of the best diving in the world. If you need contacts and connections, you let me know, and I'll see if I can line you up with guys. And as I said, for just hiking goodness, Saturdays with Dr. Kwame and Quasi, and we'll show you some of the spectacular interiors of the island of Guam that frankly not a whole lot of people have ever seen. I think you're gonna dig it. So and I know this from watching seasons of Scrubs. There's a couple of different worlds for doctors, and you can go into a discipline where we're going to work on therapies, we're going to work on curing you with drugs and different kinds of things, and then you got doctors that go, yeah, tell you what, I'm going to cut you, and whatever has gone south in there, I'm just going to pull it out and then sew you back together. And you are the latter, correct?
More or less. I think where I came from, we did split our time in my last group between the intensive care unit, kind of doing medical management of patients, as well as the operating room. So we did a little bit of both worlds, but certainly me and all my partners and colleagues always enjoyed the operating room a lot more. Being able to fix a problem right away, it's a lot more satisfying. Yeah,
there's a little bit of a Top Gun thing in there as well, isn't there? I mean,
they say Top Knife is the big book they make us read.
Top Knife, okay, yeah, because there's got to be something spectacular about being able to do that. The analogy is, you're like a mechanic, but you're working on the car while the engine is running.
Yeah, I mean, I think it's mechanics and surgeons probably have a whole lot of overlap.
Yeah.
People come in with some vague complaints, you poke and prod them a little bit, figure out what's wrong, and go try to fix it.
There's an incredible network at Guam Regional Medical City, and one of my favorite things about the place is the way the network works together, so that somebody, as you say, can come in and we might not know exactly what's happening from the very beginning, but we've got all these specialists that we can introduce you to, and they can look at your different situations, and if there's a way that they can take care of it with just diet and exercise, let's do that. We need to apply some medication, topical over here, then let's do that. But when it becomes time where there needs to be some kind of surgery, where there needs to be a general surgeon like you or somebody that's got specialties like neurosurgery, we can do that as well. So I suppose the question I'm asking here is it like that everywhere you have been, or is this kind of a unique situation for you?
Well, it should be. I think at all good hospitals that network exists, and certainly most physicians recognize that surgery is a last resort in a lot of cases.
Yeah.
And so non-operative management, medical management should be the first choice. And then multidisciplinary teams, meaning you have the internal medicine, the cardiology, the different types of specialty nurses, et cetera, working together. that always has the best outcome when it's a team.
Are there surgeries that you've done a number of times? I don't want to get to a point where you're going, yeah, I can do that surgery with my eyes closed. But are there a number of procedures that you find yourself having done over and over again?
Yeah, certainly. Common things tend to be common. So a lot of gallbladder disease, general surgeons across the world do all the time. Hernias, colon surgery, laparoscopy is kind of come into general surgery and taken over.
Wait, which one is that?
So it's minimally invasive. So things that used to require, a scar from your breastbone down to your belt, now you can have a few little stab incisions, and that makes the patients do a lot better. It, makes outcomes better. People stay in the hospital a lot shorter.
You can cover the scar with a tattoo easily.
Right. Or, just show it off.
Yeah, or show it off. You got a belly button, you show that off.
It's hard to see the laparoscopic scars from 6 feet away. But we'll still use them.
I got you. That is kind of interesting. Now, you've said gallbladder, and I'm the kind of interviewer that will nod his head and sound intelligent when I say gallbladder surgery. I don't know anything about that. So can we, for my benefit and for everybody else that is sitting in the same side going, I had an aunt who had gallbladder surgery before. I don't know how you get your gallbladder in trouble or what the symptoms are or how we take care of it under a surgeon's knife.
Well, so the basic issue that arises with gallbladder tends to be diet related. It's not necessarily anyone did anything wrong, but as we kind of eat fatty foods over the course of our life, the gallbladder hangs off onto your liver and it's just basically a storage bag for bile, which helps digest your food. And you don't need it, and your body can do fine without it, but it's nice to have a little bit of extra bile when you need it. And over time, stones can develop in there. Just like people can get kidney stones, you can get gallbladder stones or gallstones. And if those get big enough, they can block off the exit to the gallbladder, which causes it to get inflamed, and infected, and hurt. And it's pretty simple surgery to take it out. I'd say the vast majority of times it's done with a laparoscope and sometimes even outpatient surgery.
Now, this laparoscopic surgery that you're talking about, you're like stumble over these words. Yeah. That's something that we can do here on Guam. We can do that at GRMC.
Oh, certainly.
How's it? Okay, so you make a hole about the size of
5 millimeters for the holes, 10 millimeters for the big ones.
Yeah. Okay, so we do the metric conversion, half inch or an inch.
Yeah.
Okay.
Yeah.
So we do that. We make a little hole inside of you, and then you go in with what are they, like a tube with tools in it?
Yeah, they're like sticks with instruments on the end. It's something a mechanic would probably recognize as an extension.
So how do you see what you're doing?
We have fiber optic cameras.
Go in the same hole.
Huh?
I'll be darned.
Yeah.
Now, you can attack from different angles.
Yeah, you just spread them out and.
That's amazing technology. Is gee whiz sci-fi technology, I suppose, from back in the day.
Yeah.
Have we gotten to a point where we can do it? I was going to say minimally non-invasive, but have we gotten to a point where a machine can do it?
People are claiming that. People in the robotic world are pushing it pretty hard, but I don't know that they have any proof yet. The studies haven't really shown that to be beneficial for all surgeries. And then if people really on the edge are talking about artificial intelligence doing it, but I don't know that that's going to happen during my lifetime.
Well, what about by remote control? Can you operating it? I think there's an actual
people
device that does this. Where you're in California.
It, but what happens if the internet goes down?
I had that same concern when I had my LASIK surgery. I was in the Philippines at a place run by an American eye clinic run by a fella named Jack Arroyo, and he was running the equipment at the time, and it wasn't in 1997, but they were running a Windows 95 computer for the LASIK surgery, and I remember being squeamish about that because I worked with Windows 95 in what I considered to be critical situations, and I'd never trusted it. I'd never walked away, never turned my back on it, and all of a sudden I was trusting this thing to shoot lasers into my eyes and correct my distance vision. Absolutely one of the spookiest things that I'd ever done.
Yeah, I mean maybe it'll get there one day, the artificial intelligence, but I think.
And the remote control.
But
now telemedicine has certainly taken a number of great strides. Also something they can do at Guam Regional Medical City. So I don't necessarily have to be in front of you when we're making diagnosis and making our plans, right?
Yeah, and I was working in Virginia. There was also obviously COVID concerns there too, and so there was a big shift towards us doing a lot of routine follow-up, routine inquiries, either over the phone or with a webcam. And that's certainly acceptable. Obviously, if somebody has an emergency, we always direct them to the emergency department. But We can do a lot of stuff remotely now.
Oh, there was a lot of concerns. I mean, when we first started talking about this, and people figured out, wow, look at what we can use the internet for. When they figured out how to get cameras and audio working in two directions on these things, what people said, well, I'd be able to talk to a doctor and get diagnosed from thousands and thousands of miles away. And initially, there were doctors that expressed concerns about, well, wait a second, you're not certified by our Board of Medicine here to be able to perform medicine, and certainly advising patients one way or the other, or doing something like a diagnosis over the internet was not something that was welcomed by a number of people, politicians and some members of the medical community.
Yeah, I think you can get into trouble, especially if people are going outside their area of expertise or starting new drugs, those kind of things. But if you have an established relationship with a patient or a straightforward problem, I think it's a safe method. You just got to be careful. When you see those ads on the internet, we'll prescribe you this over the internet, there's probably...
They're usually a pretty good reason to stay away from those kinds of guys, as is the case in most times. Stay in well-lit places is the rule, and if you get that weird feeling, there's probably a pretty good reason to have that unusual feeling.
If you have an established doctor and you have a routine question or a follow-up, it's something that can safely be done over the internet. If you feel more comfortable staying at home, certainly.
In the surgery business, is there a lot of call for that kind of thing, where you might be looking at some X-rays or some kind of imagery and saying, I'm not really 1,000% sure. Let me see if I can send this over to my buddy in the States who sees something like this on a more common basis. Are you using telemed for that?
Yeah, that's something we do. And I think most surgeons, I can't really speak for other professions, tend to bounce things off each other all the time. It's always a team sport. And once people pretend they know everything, but if anyone actually...
No, I actually do. I actually do, which is what makes the program that much more fun. 888-8255-888-TALK. Talking with Dr. Nicholas Bandy, general surgeon, now new general surgeon, over at Guam Regional Medical City. Are you the only one of your kind there?
I'm the only full-time general surgeon directly employed by the hospital, but there's a lot of other general surgeons that rotate through.
Okay.
And so it's a...
So they've got
a lot of surgeons.
So you get to pay. Do you sleep at all? Because it sounds like, for something as busy as Guam Regional Medical City, and the number of accident prone and people who drink a beer and get in a fight and get punched in the face and have to have a jaw put back together under certain conditions. I imagine that they keep you fairly busy.
Well, yeah, we split the time. So
Robotic surgery. They're going to go over at Methodist and Herman Memorial Hospital. My buddy Gus Castro is writing in. Sabine says, welcome to Guam, Doc. And Nate Orn talking about the laparoscopy, talking about giant chopsticks is the analogy that he's using. Bill Cruz says, welcome and half a day, Doc. Hope you enjoy your stay. If you got some questions, let me know. Gus says it's cool. He really does look like a real doctor because he's got the mask on. That's why he's got the thing going on the face. There we go. So if you got something, go ahead and chime it in. Real Joe, grab that and see if that's somebody that might want to have a question for him. We will be happy to take the opportunity to answer some questions. In my case, the question is, why did you want to become a doctor? I was going to go to doctor school. I forgot, and instead went into DJ school. What's your story?
Well, the DJ was already taken at my college. No, I was. Everyone in my family had a lot of nurses, a lot of medical personnel. Kind of gravitated towards it pretty early. Got involved with EMS, kind of rescue crews in college.
Oh, no way. No, that's like riding along with cops.
Yeah. I mean, thankfully, I went to a tiny little college in the middle of nowhere, so we never saw anything too bad. But kind of caught the bug and just kept chasing it.
Yeah. Did you intern anywhere? I mean, outside of that, were you able to get an intern position?
I volunteered with the rescue squad, and I volunteered in the emergency department at the little tiny hospital near my college, which is smaller than hospitals here, actually.
How did they now? Did they let you do anything, or was it cleanup work, attendant work?
Cleaning up stuff, carrying stuff around. I mean, I was just a punk college kid, didn't know anything, but I had fun.
All right.
And the doctors would tell me what they were thinking, so that was really exciting.
Oh, it had to be. Now, how much of this science did you have to get? I mean, as a doctor, there's a lot of science. You start with the biologies.
Yeah, I was actually a chemistry major first, so I went into college thinking I was going to be a
oh God, I'm not the smartest person in the room. I'll give you that right now. I mean, chem is confounds me.
Yeah, I liked it in the beginning, and when you get to the end, chemistry just turns into math, and it was over my head. So I transitioned to medicine because it's easier.
I've never actually heard that, but I agree with you. Chemistry in the very beginning, when you start playing around with it, and then you get into the high end mathematics behind it, and I couldn't follow along.
Cutting out gallbladders is much easier.
Yeah. Well, I mean, there's technique. There is the technique that you can eventually drill yourself into.
I mean, it's a craft. It's similar to, the training's actually, if you think going way back when people had apprenticeships, that's what residency is. You follow around the doctor and do menial tasks for him all day, and you slowly do more and more advanced things under their supervision. And
well, how much fun is gross anatomy? How much? And as a surgeon, I'm sure that there was a lot of time that you had to spend with cadavers.
The anatomy lab, they do it really early in medical school, and it's fun. To be honest, even preserved, the cadavers are still pretty gross and smell horrible.
Smelly.
So it's fun. It's not nearly as fun as taking care of a real human.
I suppose. Now, in the process of becoming a surgeon, and I'm sure that you've had to deal with great successes, but I'm also sure you might have lost a couple on the table. How's that?
Yeah, there's a famous quote in surgery that every surgeon has, to paraphrase, has their own little graveyard in their head for the rest of their lives. It's something that, you live with forever and wish you could go back and do it differently. And that's where every surgeon, every doctor, every healthcare provider is always learning from their mistakes, from their colleagues' mistakes.
Yeah. And there's a network of support even for you guys as you go through those kinds of
and the other thing
scenarios.
One of the traditions in surgery is everyone's kind of brutally honest with each other. So if you screw up, you own up to it, and your partners, colleagues rip you a new one, and everyone learns from it.
Yeah, well, hopefully you do that before the legal guys get involved. And unfortunately, that is a major, in my mind, has been a major issue in medicine for quite some time, where you got guys like yourself that put all kinds of time, all kinds of investments for themselves into the mission of becoming a doctor, and then you get into the doctor world and you realize, oh my God, there's just an incredible amount of regulations, compliance, and legal that you have to learn. You almost need to become a lawyer to continue to be a practicing doctor.
Yeah, it's it's kind of just, it is what it is. You got to find a job you love. You got to keep doing it and deal with the BS. I mean, every job has
something.
It's still work, if you love it. So.
Yeah. Well, what's the work part besides that? What else is the work part of your job?
There's a ton of documentation requirements. Spending a lot of time on the computers. Thankfully, GRMC actually has a really robust computer system, but I've worked at some other hospitals where it was.
It's the one room they won't let me in. I've been on tours. I've had people that I know that have been in the hospital. They let me do what I want to do around there because I know people. But for the most part, there is that one door that they won't ever let me through. And I said, "What's behind that?" And they said, "That's 95. That's Windows 95." There we go. I'm sure it's more than Windows. In fact, this is the other thing I know about Guam Regional Medical City is if they don't have the software for something, they've got people that can write the code. We've interviewed your code guys over at GRMC before. So I mean, if there's something that's in the system, the data that they can extract and do something with, and a module doesn't exist for it, they've got people that will write that module.
Yeah, it's been nice. They've already started customizing some templates for me, and it's good. They've got people that are experts at computer that focus on that, and it frees up the medical staff to focus on the patients.
It's a fascinating conversation. I think you're lucky to work where you are. There's trauma surgery, critical care surgery. I'm going back into some of the scripted questions here. Now, I know a little bit about trauma surgery after having worked with somebody that fell off a ladder from the 3rd floor and basically tore his ankles apart when he finally hit the ground, and we categorize that as trauma surgery. And he never really recovered from that one way or the other. So is there, critical care sounds like it would be the same thing. What are the differences in the scopes of surgery that you perform?
Back in the 90s, when I was not anywhere close to being a doctor yet, there's trauma used to be if you got in a car accident, you got a huge exploratory surgery, everyone got a big scar. And then as we got better at managing things without operations, a lot of these trauma surgeons were sitting around with not much to do. So a kind of a new field evolved where people did a little bit of trauma, a little bit of ICU care, a little bit of general surgery, and they kind of combined it all together and called it like acute care surgery.
I see.
And so in order to take care of people that get shot or in car accidents, you have to know how to run the ventilator, how to do the dialysis, how to do all those things. So there's a big overlap in skill sets. And now there's a huge workforce of people who can operate and can take care of the patients before and after the operation in the ICU. And that's the training I went through.
Yeah. I was going to say that's kind of interesting because normally you think in terms of a little bit of a specialty that goes on.
Well, it is its own specialty. You go to fellowship to do this.
So
after you finish your core general surgery training, you go on and do additional training and learn how to run the ICU. And that's essentially what a trauma surgeon is now. Because you learn how to do the operating, whether or not you call yourself a trauma surgeon.
Yeah.
And then you learn how to do the how do you resuscitate somebody after they get shot?
Mm-hmm.
How do you take care of them after you operate on them?
A lot of sawbone stuff in there. 888-8255-888-TALK. I think I got Jack on the line, and he's got a question that he wanted to ask you. Good morning, Jack.
Hi, yeah. Good morning, Ray. Good morning, Doc. I have a question. A relative of mine is scheduled for an elective surgery. It's on her knee. It's bone on bone. The cartilage is totally gone, so she needs knee replacement. So we went in to GRMC, and there's a waiting list for these types of elective surgery. So she's looking at hopefully, before Christmas. And so my question is, how much of this is due because of the COVID-19, and how much of it is due because we just simply, like Dr. Vince Akamoto says, that we lack the specialists to do these types of surgery, in this case orthopedic.
Yeah.
And the doctor she's seeing has only one clinical working day. The rest, he's in the surgery room. So this has been going on for more than 2 years. So I was just wondering how much of this stuff is caused by COVID-19 and how much of this is just day-to-day operations. We just don't have...
Being out here at the end of the doctor supply chain, what do you think, Dr. Bandy?
Well, I don't actually know that I'm even qualified to answer that, to be honest. I'm sorry to give you a non-answer. That's not really my department.
Okay.
I think we probably could refer you. We can maybe offline get you some phone numbers to talk to see what's going on with the wait list. But it's
there's nothing we can do about the wait list because she can't really go off island and get this.
Well, you have a finite number of doctors and and finite number of surgical wards and surgical rooms and things like that.
I will say that the operating room at GRMC runs very efficiently, and they strive their hardest to work you in and get things done. So I think it's a very efficiently run hospital from what I've seen, having been here for a few weeks. But I don't know the particulars of this case or if there's any other information.
I'm not trying to put you on the spot. I'm just trying to figure out because we've been seeing this surgeon for over a couple of years. It's just that got to the point that she needs knee replacement, and because of the pandemic and stuff. But I got a feeling that like Dr. Akamoto says, is that we just have a short supply of specialists here. And this poor doctor, and I know there's only 2 or 3 orthopedic surgeons here. I mean, they have a full schedule. Every day, they only have 1 day for to see patients, and the rest they're spending in the OR.
Jack, you can't see it because you're on the phone, but online the response from Guam Regional Medical Cities Management is the list is not due to COVID-19. Dr. Galang is one of the busiest surgeons that they've got over at Guam Regional Medical City, and like many things out here, as I said, at the end of the supply chain, we're also at the end of the doctor chain as well as a lot of other facilities that we compete with. I mean, and nurses and anesthesiologists. I mean, it wasn't that long ago, Jack, among the complaints, you and I have been on the radio together for many years. It wasn't that long ago that was a huge complaint. We couldn't get a lot of elective surgery done because there was a shrinking number of anesthesiologists out there that were able to work with the doctors on their schedules.
Yeah, my aunt was an anesthesiologist. She passed away a couple of years ago.
Mm-hmm.
But listen, thank you for everything. Thank you for GRMC. Thank you for Dr. Galang. We don't usually get what we want, but we get what we need. And I'm just doing the best to keep my relatives comfortable and waiting for a slot to open or to wait for her to get that knee replacement. So thank you very much.
Jack, is there anything they can do with the medicine? My old man had terrible arthritic knees, and it was bone on bone before he passed away. And I know that was very painful and very difficult for him to get around. But he did have some doctors that were doing some injections, cortisone injections, and there was another crazy injection that he got in the Philippines a couple of times where they took something that came off the comb of a chicken. Do you know what I'm talking about?
I have heard a little bit about this. There's a lot of different products from a lot of different vendors, and a lot of times what they do is they derive tissue and kind of sterilize it and use that in different methods. Again, I don't do joint replacement.
Go ahead, Jack.
Yeah, my relative already has done the cortisone way, so it's just gotten to the point that we're down to knee replacement. So, anyways, just thank you very much, and prayers to all those that are waiting, and we just need to keep them comfortable, keep them safe, and we just have to wait out this crisis.
Yep,
so thank
absolutely.
you very much.
Jack, I'll talk to you soon. I appreciate your time on the phone here. A couple of questions floating around for GRMC's management. Listening to you on the air, you've got GRMC on the program. I understand GRMC has Guam Guard medics at the hospital, and they're designated as a non-COVID-19 hospital. Please confirm if Guam Guard medics are at GRMC, and ask why Guam Guard medics are working at GRMC. Is it true that we've got Guam Guard folks that are at the hospital in the capacity of the hospital?
At this moment,
All right. All right, no confirmation one way or the other. All right, but could you do me a favor and check and see if you can get back to me on that? Inquiring minds want to know. 888-825-5888-TALK. What is the most challenging case that you've got in your head? You know, we talk about being a surgeon, and I've got to imagine that there have been times where you go, would you look at that? Get the camera, and I got to take pictures of this, and nobody's going to believe that I'd ever done it.
It's certainly kind of big categories. Reoperative surgery is always hard, regardless of your specialty. So doing a repeat joint replacement, for example, or in the general surgery world, somebody who's had multiple abdominal surgeries, just like you get a scar in your arm, on the inside you get a ton of scar tissue too. So anytime you're doing a repeat surgery is very technically challenging. On the more kind of outside of the operating room, outside of the technical world, just challenges kind of intellectually is if you have somebody, let's say they have a cancer on their colon, but maybe they have advanced heart failure, they're on oxygen already, they have renal failure, they have all these competing comorbidities. Sometimes you get in that scenario where you can technically remove an organ, but you don't know that they'll survive the operation because of their medical status. And that can be the hardest to walk the families through that, where you're going to say, no, we're not going to we're going to leave the tumor behind, for example, or if somebody has abdominal infection where you could go in and potentially resect something, and those can be a little harder, particularly for families, because, you know, it's tough when we talk about all these robots and laparoscopic. It's hard for people to understand why we would sometimes say no.
Because it is possible that the patient might not survive the trauma of the surgery.
Or even worse, they may survive and be stuck in the ICU on the ventilator for weeks and weeks.
I've seen ventilator cases before, and it is distressing to see when somebody that you love is in that situation. And the crazy thing is there are times where the eyes open and it looks like there's somebody inside and they're trying to communicate. As I said, you know, it's a distressing thing to see. And prayers for anybody that has ever had to endure that. There is a popular meme that is floating around that basically says, "Oh, you don't like masks, or you're going to hate the ventilators even more." Walk me through that process, if you don't mind. I just want to, because there are mask deniers, and to a degree, I'm one of them. But I consider myself to be fairly young and very healthy, and not likely to pick up COVID. And if I do, I'm probably going to survive it. For other people with comorbidities, other people that are sick, that aren't wearing masks, tell me about the ventilator process and what needs to be done in order to make it so that your body will accept this foreign item in your throat.
So I'll just kind of talk about the ventilator directly and not necessarily the statistics of COVID. I'm not a statistician.
I'm not looking for a COVID story.
In terms of the ventilator, it depends on your level of consciousness. So if, let's say, somebody has a severe head injury and they're essentially comatose, you can just put the tube in it. And sometimes the paramedics do that and don't even need to give drugs. Yeah. Now, let's say any of us in this room were to have to get a ventilator for, let's say you're going to get a surgery or something like that. Essentially, and I'd like to explain to families, when water goes down the wrong pipe, when we say that as a kid, and you feel that choking sensation, and you cough and you tear up, that's kind of the very minimal start of that reflex. So as the tube goes down between your vocal cords, you're triggering a very strong gag reflex, and it's extremely distressing in terms of anxiety-provoking, and can be painful as well. Depending on the ventilator settings, it may or may not be breathing for you. Sometimes it just provides oxygen, but usually if somebody's in the ventilator, it's actually mechanically pushing their chest out. And so if somebody's a little bit confused and agitated, they may actually actively fight that. Yeah. So in general, if somebody's going to be on the ventilator, we need to have them sedated to the point where they won't have those reflexes and have that distress, and a little bit of pain medicine usually, because the tube itself can be painful. Yeah. So being put on the ventilator for a surgery where you're totally comatose for a few hours, that's not that big of a deal. But if somebody's stuck on the ventilator for days to weeks, they can have, there's actually a lot of studies out there, they can have PTSD even from that experience. if they're not properly sedated.
Yeah, well, I was very young when I had my stomach pumped. I'd eaten an entire bottle of St. Joseph's aspirin because it was tasty. I thought it was candy, and I ate the whole thing. And they took me to Guam Memorial Hospital and pumped my stomach, and I was alert for the whole thing. Yeah. And I remember that as being one of the most traumatic experiences of my life to this day. Yeah. And so I can only imagine what it must feel like when you've got that thing, as you say, down in your throat for the entire time that you're there. It's an interesting conversation. I hope I'm learning a lot. I hope you're learning a lot as well. General surgery has always been available at Guam Regional Medical City. They've got a new guy in town, and he's here for the hail and welcome aboard on the Points broadcast. It's 9:36 in the morning. Let's call that Eye Connect time real quick. They're closed virtually everywhere. Minimal activities in the main office, and the mall store location is, like everything else around here, shut down. You can still do business, and we recommend if there's something that you need from Eye Connect or somebody you need to talk to, start with a phone call, and they'll work out the rest of it, up to and including maybe dropping off instruments or having you go pick them up curbside over at the mall. 888-8888.
They're back. Any footlong is a $5 footlong when you buy one at regular price. At participating locations, Subway, eat fresh.
Is your company providing the best management practices to create a safe workplace? Injuries could cost you a great deal of financial stress. OSH Solutions offers safety training and consultation services including OSHA, USDOT Hazmat, CPR, and forklifts that meet or exceed expectations. They provide on-site consultation support to companies in construction and general industries. Safeguard your business with OSH Solutions today. Call 969-0734.
Top End Pest Control is who you call for all your pest control needs. Got a problem with roaches, ants, spiders, rodents, fleas, ticks, termites? No problem. They do it all. Top End Pest Control is a service-disabled, veteran-owned small business and HubZone certified, serving Guam since 2012. Call them today for a quote, 487-5657, or email topendpest@gmail.com. Check them out on Facebook at Top End Pest Control and give them a like. Top End Pest Control for all your pest control needs. At 9:38, and sometimes I go, we should have two channels going, one with the commercials and one where because we're still talking in here, and you know, Bill Cruz is online, says, "Oh, please stop! You're bringing back some memories, maybe of a time that Bill had been on some kind of a ventilator device, or even just long ICU stays and things like that." We were talking initially, and I remember in my head about a couple of people that I'd visited in the hospital, and I'll ask them afterwards. I'll say, "Hey, I was there. I was in the hospital with you. Do you remember?" And I said, "Nah." I said, "But your eyes were open and you were squeezing my hand. I thought you knew what was going on." And but the truth of the matter is, these guys were so deep into the la-la land and under the medication that they didn't know anything that was going on. Those were just simple reflexes, right?
It can be, yeah, or it can be. It can be a reflex. The hand squeeze. You know, whenever anyone's played with an infant, you can put your finger in their hand and they can grasp it. It doesn't mean they understand. So sometimes we can be fooled by, you know.
Well, you want things. You want to be able to say, all right, everything.
It's
everything
so hard when it's your loved one and their eyes move. Of course, you think they're recognizing you, but that's unfortunately not always the case.
Yeah. Well, here's the thing, and the other thing that we were talking about is, you know, it's the fate worse than death, and you know, I don't want to die, but I don't want to live forever too. I've seen some of the situations that older folks and infirm folks have gone through, and I don't know that I ever want to. I don't want to go out like that, if you know what I mean.
Yeah, I think it's important that everyone has a strong discussion with their family and loved one about what they want. Mm-hmm. You know, advanced directive or a formal document with a lawyer can help, or just the conversation with your family.
DNRs, things like that.
Yeah,
no heroic actions in order to save my life. If I've gone down this bad, then the road back to normal is going to be hell. So just let me go. It's been a good life, and those kinds of things. Unfortunately, it's one of the things that you've got to deal with at any stage in this. And like I said, I've learned a lot from you in the conversation. You have taught this, haven't you? The skills that you have, you've passed them along to students?
Yeah, my last job, I was a professor at a medical school, Eastern Virginia Medical School. I trained there, and then I stayed on. And it's kind of, I mentioned earlier, it's almost like an apprenticeship type style of teaching.
Yeah.
bring the students and residents around with you on rounds. You ask them questions till they say, I don't know. And they get very distressed, but normally they know a lot more than they think. And it's a fun process to see them develop over the years.
Yeah.
And then, as you go to the operating room, you start off letting them put 1 or 2 little stitches in. And by the time somebody's a chief resident, they're essentially doing almost all the case with your immediate direct assistance and supervision. So it's a process I went through and really enjoyed, and it's a process I enjoyed back home. Now, that being said, you don't need to be in a university to do that, because any hospital, people are always learning from each other. So I've already done a couple cases here where one of the wound care specialist nurses have come into the operating room with me, and we've been bouncing ideas off each other. So we're always learning.
Well, and there's interesting wound care that we can do here. One of the other specialties over at GRMC is you've got a hyperbaric chamber.
I think as of right now, they're still trying to fill that role.
Wait, I thought, what happened to Anthony? Where'd she go? Didn't we have a hyperbaric at GRMC?
We did.
You did? Okay. Did we shut it down? Is it broken?
No.
Oh.
We actually have a new hyperbaric chamber.
Okay.
Equipment.
Let me see if we can get your microphone on. It's possible. No, we'd have to use the other one. Here, use the other camera microphone. That one. There we go. Try again. Jerry's mic.
Yes, we do have a new hyperbaric chamber unit, and we're currently working with our staffing to continue the services of the hyperbaric and wound care.
Okay, gotcha. But and so I guess more to the point here for you, Doc, is there is that capability, and I know that specifically for diabetics, and there are other wound care options that you've got when you've got a hyperbaric chamber. Keep the infection rate down.
Yeah, there's a lot of different ways to tackle wounds. Hyperbarics is not something that I do or where I've trained before was commonly done, but we certainly have a lot of wound care strategies, a big spectrum of interventions from, less invasive to more invasive, and it's something we take care of as general surgeons.
Yeah. Tell me a little bit. I'm sorry to bounce around here. There was a question that I had before we were talking about wound care, and I wanted to bring up the hyperbaric chamber just because I always thought it was a big deal. But getting back into the subject of surgery, teaching, and things like that, tell me about your first surgery, the first time that somebody said, okay, you're driving the whole thing. Do you remember what that case was about?
I don't remember the first. It's such an unsatisfying answer, but generally as an intern, a lot of what you do is the abscesses and stuff like that. So they're teaching you how to open a big wound and get it cleaned out. And then you might assist where the chief resident's doing the case with the attending surgeon, and you as the intern might be holding the laparoscopic camera.
Okay.
So you can see you're a few feet away, probably less than 6 feet, but you're there and you can see everything, and you kind of just slowly build what they let you do over time.
And so it was one of those cases where you were the only, you were the surgeon on duty. You were the guy that was there, and it was a natural evolution to get to that. It's not like there was a graduation ceremony, right?
It is kind of funny. In medicine, they have these artificial cutoff dates where on July 1st, all of a sudden you're no longer an intern, you're now the second-year resident, and all of a sudden you're responsible. And it's kind of funny because you're like, well, 3 hours ago I wasn't allowed to do this. So there's a little bit of artificial deadlines in training, just like I'm sure in the military and ranks and those kind of things. Like, is it really, what's the difference when you change your rank?
Or just somebody has decided that you're more capable than...
they have to. I mean, they have...
Than you were the day
prior. There's very formal progressions where you have to meet milestones and take tests and those kind of things. So it's all supervised and safe. But it is a little funny where one day you're a resident, the next day you're full-fledged doctor, and all that happened was you went to bed the night before.
Yeah. Did you ever want to do anything different?
Do I now, or did I?
well, I suppose at any point in the journey. I mean, all right. So I'm 40 plus years in broadcasting. As far as I know, I've never ever wanted to do anything, except every once in a while. I get this hankering in my head that I want to do a couple of different things. Either a part-time job over at Home Depot. Or a full-time job at one of the dive facilities that we've got here on Guam, and just hang out on boats and dive with tourist chicks all day.
No, I mean, I love my job. Obviously everyone's got good days and bad days, and sometimes you kind of have little fantasies. Or what if I was, when I was in high school, I worked with a guy that restored Model Ts for fun. And that was probably the coolest thing I've ever done in my life outside of surgery. And but I couldn't not do this.
Yeah, but there we go again. I mean, it goes back to the original conversation that we started with. Is the difference between a mechanic and a surgeon. And so you think about restoring a Model T. How far off of that is?
The difference is student loans and a bunch of tests.
and there's that. And there's that. Yeah. And there's that. What is your wife doing in the Navy? Anything fun?
Pediatrician.
She's a pediatrician. So oh my God, 2 doctors under the same roof. Yeah. Can you imagine that? There's got to be some crazy talk over the kitchen table, right. over different ways to manage cases.
The table is run by a 2-year-old, so the Daniel Tiger talk right now.
Yeah, there's well, I mean, you got that shark song too.
She's pretty good at that. Yeah,
I'll bet they are. Listen, thanks very much for coming by the radio station. Any idea? Are you here for as long as your wife is going to be here?
We're here at least 3 years.
Mm-hmm. And then, do you have any ideas on where you might want to go after that, or is that all dependent on where the Pentagon wants to send her?
I think we're getting a little. It's hard for us to plan that far out, to be honest. I think what I've learned about the Navy is don't make any long-term plans.
Yeah, and long-term can be the end between here and the end of the week.
Yeah, but I think we're loving where we're at and we're having fun, so I think we'll just keep going for now.
Well, have you ever served? Were you ever in the military?
No.
Are there options? I mean, you still look like a fairly young man. Is it possible that you could join the military and specifically going into the medical field in the military? We were talking about the Mercy ship and that was out off the coast of New York that didn't do anything except an appendectomy for the entire COVID when they were parked out there because Cuomo freaked out.
Yeah, it is an option. I don't think it's one that messes with my career goals.
Yeah. Well, it was one of the opportunities that they gave me when I was a kid, when I took the ASVAB, and they wouldn't let me into flight school and they wouldn't let me into journalism school, and they said, "We'll send you to doctor school," and I turned them down because I was stupid when I was 18 years old. I'd be a doctor and I'd be out and I wouldn't have any bills to pay if that was the case. 9:47. No doctor gets to sit in that chair without answering a couple of other questions. I'm not huge on pills. I'm very fortunate that at 58 years old, about the only pills I take anymore, an occasional Tylenol if I've got a headache or if I stepped out on the trail the wrong way and I need to relax the muscles. But other than that, I don't take any other pills. There's nothing I take consistent medication or anything like that. But vitamins, when I remember to take them. What is your position on vitamins, father of a 2-year-old?
I think obviously if you have a deficit, you probably need to take something, but you should probably just eat a good balanced diet and go from there.
Okay, well, that's that. See, now you got me there. Dinner last night was beer and pizza. Yeah. Well, probably should invest in some vitamins.
It was more than a Budweiser.
Well, it was a couple. It was a Honey Kolsch, as a matter of fact.
That might count.
That might count as a part. See, now this one I like. Most of the rest of the ones that they bring in from GRMC, they're like, oh, it's a diet and exercise, and I tell them, yeah, well, how about a Hormel chili with no beans and hot dogs in it and all of that, and a couple of beers to wash it all down. And they just kind of look at me and say, why aren't you dead yet? Is the thing, and that's the answer. It's a bachelor diet, and that's what I'm about.
Oh no, you have to go see your internist, and they're going to yell at you.
Oh, that's fine. I get the lecture from the internist. I get the lecture from my dentist, but I can beat them all on the marathon tracks.
Well, I'm just hoping you get gallstones so we can take your gallbladder
out. There might be some. I wouldn't know what are the symptoms. I might already have it.
So the classic symptoms is middle-aged people. It used to say more females than males, but I don't know if that's necessarily true anymore. And so after somebody eats a big meal, they might kind of have some cramping, some bloating, pain in the right upper quadrant up under your ribs. Some people get a little nauseated and gassy.
I thought that was from the beer.
Well,
I thought it was some weird kind of fatty liver thing that I might have. But if it is, then
the classic is somebody comes in. I had a big piece of pizza, hurt for about an hour or two, then it went away. Every time I have that, it happens over and over again, and sometimes it gets worse with time.
Yeah. Okay, no, I don't know. The last couple of physicals I've had, they put me down as ultra healthy, so I'm going to assume that I don't have that. But I will, the next time I feel that tickle in the upper right quadrant behind the ribs, then I'll think about you, and then maybe you can go and we can do. How would you find something like that? I mean, is
ultrasound.
With just ultrasound?
Yeah.
Basic. I mean, I don't have to even get in the 64 slice toaster that you guys have there.
No.
I think it's 75 slices now. You guys have upgraded since the last time I've talked. I've talked to the imagery guys all the time, and that's another one of these places where I just get enamored with the technology that you guys get to work with in so many different ways that you can look inside the body. So vitamins probably no, and diet. My particular diet and exercise seems to be working out for me.
Well, I'm biased. I want you to get gallbladder disease.
There we go. So we can be the doctor. 9:50 in the morning. The fellow's name is, and you can ask for him by name, Nicholas Bandy, general surgeon over at Guam Regional Medical City. And generally, the way it works is the patients don't come and see you directly. They kind of got to get referred by somebody else before you get to be my surgeon, right?
Right. So if somebody's coming on an outpatient basis, we get a referral and sent in. A lot of times we see people because they're already admitted to the hospital for something else, or they're in the emergency department.
Okay, so if I came in...
Obviously, we like to see people in the office before it's an emergency.
Okay, broken bones, you can do that?
We orthopedics.
We got orthopedics. But you get to cut, though, right?
If it's... every once in a while you're talking about like your friend that fell off a ladder. If it's combined where there's muscle injury and vascular injury and orthopedic injuries, it might be a multidisciplinary team. But generally, bones fractures are dealt with by orthopedic surgeons.
So how would I get to see you if I had to come in through the emergency room?
The emergency department physicians are there 24/7. They see you and they kind of decide, okay, this person needs doctors X, Y, and Z, and they call them. We drive in and see them there.
Okay, gotcha. I was just kind of curious if there was a more direct method other than getting a referral. Fun conversation. Guy's name is Dr. Nicholas Bandy, general surgeon over at Guam Regional Medical City. There was a question online here asking about whether or not Guam Regional Medical City was going to be expanding their operations anytime soon to provide even more specialties and more different offices and clinic space to deal with all of that. So I'm going to ask on this microphone over here with the camera on it of Guam Regional Medical City Management, Charlie Laurent, to find out a little bit more. Because the last time we were talking, there was supposed to be all kinds of construction going on for Phase 2 of GRMC. What's the latest on that?
Well, if you're talking about the Medical Arts Building, that's located right in front of the hospital. That's actually owned by Caesar Cabot.
Right. That's my lawyer. Not really, but...
So they're actually, our understanding of the building is to complement the hospital.
I see.
But it's still not in fully constructed, but it looks like it's getting there.
Okay.
So hopefully down the line we can have services there that complement the hospital. But in terms of the hospital services, we are constantly looking for specialists.
Right.
And that's the reason why we have a huge specialty clinic at the hospital and having services and providers here to help give you services that we don't have on island, and that you can see a provider on island instead of flying off island. That's always our purpose.
Right, and one of the big scores a few months ago, we had the opportunity to interview the rheumatologist, which was something that we had needed here on Guam for literally decades, with a number of general practitioners saying, okay, well, this is actually somebody else's specialty, but we don't have that guy here on Guam, and they do now over at Guam Regional Medical City. Some incredible people doing some great work. They are your specialty care headquarters, as a matter of fact, over at GRMC. Thanks for bringing the doctor in.
Yes,
I appreciate that. Next time we'll do some pictures.
All right.
Next time, bring WhatsApp me some cool pictures of very, very cool surgery stuff. Except the guy that shot himself in the where. Have you seen that video?
Which one?
Which one? I don't know. It's the one I can't unsee. It was the guy that was putting his Glock down his pants and accidentally shot himself. What's that?
Plaxico Burress?
I don't know if is that the name of the procedure?
Is that NFL?
Is that where? Oh, I was going to say, is that where he shot? That's the clinical name for where he shot himself.